Burns are also classified by the total body surface area that has been damaged. Major burns are usually transferred to a specialized burn center after treatment in a local ER. Moderate burns are treated on an inpatient basis at the receiving hospital, and minor burns initially may be seen in the ER or in a doctor's office and then treated in outpatient care. Assessment of the burn injury is classified by the risk of mortality or cosmetic or functional disability. The severity is influenced by burn depth, so deep, partial, and full thickness have increased risk of infection, more severe systemic effects, and increased risk of scarring and skin contractures, so they're given higher priority. With burn size, mortality increases with increasing extent of burns, and the extent of the burn most accurate after the initial debridement, and thus should be re-evaluated at that time. So you'll do an initial assessment of the burn size and then reevaluate after debridement has been done. Burn location. Head, neck, and chest have increased pulmonary complications. Hands and joints are at increased risk of physical or vocational disability. And in the perineal area, autocontamination is a high risk. And circumferential burns contribute to a tourniquet-like effect. So that area is at risk for reduced circulation and therefore further complications. If the patient is less than 4 years old or 65 or older, they have an increased death rate. Older patients have a slower reaction, impaired judgment, decreased mobility. They have the thinning of the skin, atrophy of skin appendages, and there's added environmental hazards. The general health of the patient also contributes to our assessment and will contribute to the care that we provide them. Patients with debilitating cardiac, pulmonary, endocrine, or renal disease, or diabetes or alcohol-related diseases contribute to longer hospital stays and more complications. The mechanism of injury, if it is in an enclosed space or an open space, it will determine how we provide care to the patient and any additional considerations that we need to make, any associated trauma, concentration, and duration of exposure, or whether irrigation was initiated, what the electrical source or voltage was, all play into the care that we provide our patient that is burned. Other factors might be past medical history, and it's important to note their general overall health, whether they have any allergies, and of course any medications that they are taking, including over-the-counter or herbal remedies. Estimation of the burn is done by a rule of nines or Palmar method. These are quick methods to estimate burn size in the total body surface area. You do have this information in both your Med-Surg book as well as I have put documents on Canvas for you to review, print down, whatever you would like to do. With the rule of nines, the body is divided into anatomic sections and a number for the body surface area. And it varies depending on adult, child, as well as infant. Now, bearing in mind, rule of nines is not the preferred mode of measurement under the age of 5. The Lund-Browder chart is considered the most accurate of all the methods as it assigns a specific number to each body part. This method is most often used to measure burns in infants and young children because it allows for developmental changes in percentages of body surface area. And this is in your maternal health book. And these charts are based on the percentage of burn relative to growth at different ages. However, the preferred method for your infants or to measure smaller burns is the palm method. It is a tool whereby the size of the patient's palm is used as an indicator for specific percentage of total body surface area. This method is particularly useful where the burn is an irregular shape or has a scattered distribution. And there is also the Virchow formula, which is also in your Med-Surg book.